Keith, can I make a comment on all of this? I mean, Jason said before about the high LDH, and it's looking like Nivo-Ipi may be very effective, and Jeff supported that. One thing that I think we're crying out for is some consistency across the trials in terms of reporting subgroups and reporting endpoints in those subgroups. So, for example, as you discussed before, Jason, with dabrafenib and trametinib, we've done an analysis looking at the long-term survivors, reporting on the survival, 3-year survival, people with the normal LDH, people with the high LDH, people with the LDH 2 times the upper limit of normal, PFS in that group, those groups, and OS in those groups. I would like to see those subgroups pooled across all treatments so that we can make a better assessment and have better discussions. Because although I can tell you the 3-year survival in a normal LDH patient on dabrafenib and trametinib is 70%, I can't tell you that for single-agent anti-PD-1, and I can't tell you that for Nivo-Ipi yet, but that's because it hasn't accrued. But I can't even tell you the 1-year overall survival from the 069 data. That's the Ipi versus Ipi plus Nivo. So I think some consistency across the board in looking at these subgroups and endpoints so that we can have really good discussions about first-line treatment.
Well, you know, it's not going to be 70%. I mean, it's 62% or 64% depending on the group at 2 years in that.
No, that's the overall group.
Yeah.
But I want to know the normal LDH.
Oh, breaking it out.
Yeah.
Yes,
Every
I
trial
agree.
needs
Only
to
because you have in the real world, you have a patient walking in your office who's not the average patient.
Yeah.
It's an individual patient who's got features that you can glean, like gender, age.
All of us agree that BMS needs to tell us with the breakouts, which, to be honest, were not pre-planned. They were not stratified. So these are post-hoc analyses with all the dangers inherent.
That's what we got, though.
For the pooled 067 and 069 trials, you have 400 patients who got Ipi-Nivo. Within those groups, you're going to have a significant number. I'm sure they all had LDH. They obviously all had sites of disease and disease burden assessed. I would love to see the breakouts similar to what you presented in your recent JCO article. I agree.
And if we could, and Merck need to hear the same message as well, or anyone developing any compounds in this space. These are the endpoints we need so we can have proper conversations.
Well, we'll leave it summarized that basically patients with lower disease burden do better on all of our therapies. Patients with higher disease burden do less well on all of our therapies.
Although, was that really true at that presentation we heard yesterday? You were there, I think.
Which?
There was a presentation from UCSF on prognostic factors. Unless I heard it wrong, it looked as if with PD-1 antibodies, it went the other way with LDH. High LDH, I thought, did a little better, and females did worse, which was kind of interesting.
Right, I saw that poster. An interesting point. I mean, we do have the benefit of trials now that accrued hundreds and hundreds, if not thousands, of patients in aggregate. So the poster, I think, 130 some odd patients, intriguing, and a liver metastasis element of that as well. But no, I think this is just over time, the type of evidence that we need to actually be able to talk to patients about comparative efficacy.
And to be fair, Merck did present something in 2014 from their phase 1 study. Again, it wasn't the 655 we now have that showed that LDH was strongly associated with a poorer response, high LDH, poorer response, and poorer overall survival for pembrolizumab. But we need now to do it now that we've got more data, more patients, more numbers, and more mature data to make these, yes, they're post hoc, but that's all we have.
Yeah. So, Jonathan, just one last question about this sort of kinetics of response issue. So, as I was talking about with Jeff a moment ago, I mean, Ipi-Nivo does seem to have a very high response rate and pretty rapid onset. So, going back to the pre-surgical context, I mean, has your group had any experience? I mean, it's a tough regimen, admittedly, and maybe could complicate matters going into the operating room. But is that a regimen you could use in a pre-surgical context?
You could definitely use it. I think right now in our algorithm for approaching the patient would be BRAF plus or minus MEK. If not, then we use Pembro alone. But definitely you can use Ipi-Nivo. I guess in the patients with very high disease burden or rapidly progressing, maybe that would be our younger patients would be ideal candidates to use the combination therapy in a pre-surgical setting.